celebrate mainly to create an awareness regarding epilepsy and the problems faced by the patients with epilepsy, their parents, especially with children, the parents and their other comorbidities also, and regarding the management and what are the problems faced by these children. So, as specialists are increasing, the general pediatrician is going away and away from epilepsy management. But the thing is, the disease is very common, and many places there may be the only person who is having some knowledge regarding epilepsy will be the general pediatrician. So we have to empower general pediatrician regarding the basic ideas regarding epilepsy, and also once the case is diagnosed and then the continuing care and the comorbidities and the management, and when the patient needs a referral to a higher center, and once the patient is having the full management, that is the diagnosis is made and the drug is started, then the further monthly follow-up can be done in the local center by the pediatrician. So pediatrician's role is very high, because those who are dealing with adults may not be able to understand the problems faced by the children, especially with regard to education, the problems at school, then so many other comorbidities, the hyperactivities, some will have autistic tendencies, all will not be recognized by the adult neurologist. So pediatrician is actually in a better position to manage this, and those who are working outside, I can say Trivandrum and Ernakulam, will be seeing more cases of epilepsy compared to those where there are like a galaxy of eminent pediatric neurologists are there. So I am not spending much of the time, and I'm inviting Dr. Riaz to say a few words. He's the IAP president at Kerala, and he's very much
Respected
interested.
President of IAP Trivandrum, Dr. Kalpana Madam, our dear teachers, Kunya sir, Srinivasan sir, Andeshan sir, and all the seniors here, and my dear friends. As Kalpana Madam was telling, nowadays I think seizures are one of the prominent reasons or important reasons for admissions in a pediatric ward. And most of the cases of epilepsy are managed by pediatricians. So it is very important that we pediatricians keep updated about the current management guidelines. And also we need to decide on which seizure to evaluate, which seizure to treat, how long to treat, as well as to monitor for the side effects of the drugs. So I think this session will be a very useful one for all of us. I congratulate IAP Trivandrum branch as well as the Pediatric Neurology chapter for organizing this in connection with the Epilepsy Day. All the best, and I wish a happy learning for everyone. Thank you.
Over to Dr. Mini for introducing. I'll be introducing Dr. Mini. You may be knowing there is no need for introducing Dr. Mini, because Dr. Mini is the professor of pediatric neurology in Trivandrum Medical College, and she's one of the prominent epileptologists. She had the postdoctoral fellowship in epilepsy from Sri Chitra Tirunal Medical Center, and she's is looking after children with epilepsy for some 20 years or more, and there is no other apt person to lead the discussion than Dr. Mini. Over to Dr. Mini.
Thank you, Dr. Kalpana, and good evening, everybody, and welcome Ananda Madam. Madam is the most senior person among us, and I had invited her to share her experience and opinion. So we will move on to the topic. So we are discussing on childhood epilepsy demystified, actionable tips for busy pediatricians. So the experts today are Professor Mohammed Unyu sir. I think he doesn't require any introduction to this audience. Also Dr. G.C. Shibu, was our secretary of AOPN, and she also is well known to all of us. She was trained by SAT Hospital as a pediatric neuro fellow, and then she joined the private hospitals here, and she is now a leading pediatric neurologist in the private hospitals, KIMS, SP Fort Hospital, as well as PRS Hospital. And probably Dr. Rakesh is less known among the pediatric specialists here. Dr. Rakesh, he did his MBBS from Alappuzha, and then his MD in pediatrics from Goa, and thereafter he joined Alappuzha Medical College again to complete his DM course. He's trained by none other than Professor Vinayan in pediatric epilepsies. So welcome to you all, sir, and Dr. Jizzy and Dr. Rakesh. So what we are planning is to present certain scenarios, and then the experts will be answering on that. And to the end of towards the end of the session, we can have opinion from experts, and we will answer the questions and wind up. Okay. So shall I start, sir?
Yes. Start, please.
So we'll first start with the idea of what is epilepsy. Kunja sir.
Okay, I think people all know about epilepsy, but when we ask about what is epilepsy, many times differing etiologies and descriptions will come. That is why we have a program, British Pediatric Neurology Association, BPNA, where we are giving a PET course, that is the Pediatric Epilepsy Training Program. There we get people from different corners of India, and then we start this question to them also. But people, many will be having an excellent idea about the seizures, but many may be confused with that. But practically speaking, because we know that there should be, to say that it is epilepsy, because epilepsy is one condition where there is a chance of recurrent seizures. And what type of seizures? It should be epileptic seizures, because there are a lot of non-epileptic seizures which are known to all our pediatricians, starting from breath holding spell, reflex anoxic seizure, syncope with tonic spasm. All these are non-epileptic seizures, because there is no enduring predisposition to generate epileptic seizures. So earlier we all tried to define epilepsy as where more than one episode of seizure occurs before terming it as epilepsy. And so that will be giving an idea that there is an enduring predisposition for epilepsy. Nowadays we have an idea that the International League Against Epilepsy has modified the definition, where again this definition of two consecutive seizures are primarily there. Along with that, they will be telling other parameters for telling it as an epileptic seizure. Okay, and we know that there is an increased abnormal or excessive synchronous neuronal activity in the brain. That is, it is not asynchronous but synchronous. That is why the known movements, known activities, chewing movements, motor movements, all will be occurring. Okay. Okay, Mini. You lost your connection?
I lost my connectivity, sir. Dr. Kalpana will join because there is some issues with my internet, it seems. So Dr. Kalpana will be showing the slide. Sorry for that.
Gopi, can you please give me the co-host? I'll just share the slides.
Okay, ma'am.
സാറിന്റെ സൗണ്ട് കുറച്ച് കുറവായിട്ട് എനിക്ക് തോന്നുന്നു.
Kalpana has to now run the slides, isn't it?
അതെ.
So that, okay. Continue.
Madam share ചെയ്തോളൂ. Madam co-host ആയിട്ടുണ്ട്.
I just tell the next step in the diagnosis of epilepsy also, where we will say that an epilepsy can occur. As I mentioned, it is more than 2 seizures, but there is a recurrent chances of getting epilepsy. Especially, we will say that more than 60% chance of getting.
Is the screen visible?
No.
No, madam.
Okay, I'll do it.
So, and then a reflex seizure or an epileptic syndrome, because you know that when a diagnosis of syndrome is made, you know that it can be an
Is
epileptic
visible now?
condition.
Yes.
Now it is visible.
Slideshow.
Go to the slideshow. Okay.
Transient occurrence.
Just, I was answering, I think, the next part.
Next slide, to
can
definition
Ah.
of.
So these were the practical clinical definition of epilepsy by the ILA task force, which has come in 2017. And I have already mentioned at least 2 unprovoked seizures occurring more than 24 apart, or 1 unprovoked seizure and a probability of further seizures similar to the general recurrences, that is at least 60%. After 2 unprovoked seizures occurring usually, see, when a person has a possibility of a 60% recurrence, these are all assumptions. Then diagnose an epilepsy syndrome like a benign select or a juvenile myoclonic epilepsy. Such situations definitely only even a single seizure in a young girl, in an adolescent girl, she gets an early morning seizure. Then we will have to think of an epileptic syndrome, and chances of getting recurrences will be there. So such situations definitely will give a diagnosis of epilepsy in that condition also.
Okay. The next, I'll share the screen because I have to show a video.
Okay.
Now you
Then
have.
I have to stop sharing.
You can see this screen. I hope this is visible.
Okay.
Your daughter to that hotspot.
Yes. So slideshow.
So just presenting a case of a 10-year-old boy who was brought with a history of unresponsiveness and chewing movements of 2 minutes followed by drowsiness lasting for 15 minutes. So this is the.
When did it happen?
Now, just I was asking on what is means as provoked seizure or unprovoked seizure, sir.
Okay. Someone is answering, Oh, it was Mini's slide. So it's a
Mini, just continue this.
No, I was asking, sir, what is provoked seizure or an acute symptomatic seizure and unprovoked seizure?
Yes, transient factor acting on the otherwise normal brain to temporarily lower the seizure threshold, because many times people will come and ask why this is happening only at this point of time, in between why this is not happening. Because you will describe that because certain factors which are not known fully to us, that triggers seizure and this. And many reflex activities also can produce seizures. And then symptomatic seizures, both acute symptomatic seizures and then long-term conditions also can have, because in this case showing a hyperintensity involving the temporal lobe, and it's an acute situation, isn't it? And you should have told that whether there is because this case a fever will be there, isn't it? Is a fever?
This slide, this child had an unresponsive chewing movements and drowsiness lasting for 15 minutes, and the MRI was showing some lesion. So this was reported as ganglioglioma. So I was about to ask whether it is a provoked seizure or unprovoked seizure in such a situation.
Okay.
So yeah.
Very good, because when same picture, if there is a fever is there, you have to think of herpes simplex encephalitis also, because the site is, but here definite mass effect is there. So definitely it should be something other than encephalitis.
So the point I'm trying to highlight was that even though there is a lesion, it need not be provoked, because gangliogloma is one of the well-known tumors, grade 1 WHO tumors, which is associated with epilepsy. It just presents as epilepsy. So it need not be taken as an acute symptomatic seizure. Here there is an underlying etiology. So there is a gray zone between what is provoked and unprovoked. That is what I was trying to show. And here I'll be showing video. And I want one of the attendees, I have asked Dr. Lakshmi, the first year resident who has joined now, to see this video and to describe what event is going on. And then we will move on with the rest of the presentation. She'll describe what she is seeing. Lakshmi, are you there?
Yes, ma'am.
Okay, so just describe what you see. Okay. And others can also see and make out what is going on. Okay.
I think your streaming is not that correct, because you haven't done an optimization of the video. That is why it is going in a very slow manner. Because I think is Lakshmi able to describe it? Describe the finding.
I think it's a bit slow, but
we can appreciate. Then tell.
I think both initially only left lower limb was having a little bit tonic-clonic movements were there, and left hand was had posturing, and the child had teeth, bruxism, like teeth was there were continuous movement of mouth was there. I was not able to appreciate that.
Okay, did you hear something the child was asking for?
No, I couldn't hear him.
Okay, she was asking for water and showing gestures.
Yeah, he was showing. He was showing gestures.
At the beginning, she was responding. She was wiping her face with the right hand, right?
Yeah.
And the left hand throughout the movement, throughout this event was just kept immobile.
Yeah, immobile. Yeah.
And she was asking for water, then just rubbing her abdomen in between. Yeah. So many movements were there, making chewing movements or automatisms, what that is called. Right hand was always moving, but the left hand was kept immobile, and the legs are also finally were showing some cyclical movement like things. Towards the end, we don't know whether she was responding because nobody was checking her response. So Lakshmi has interpreted this as a tonic-clonic seizure. So I just showed this video once and asked Lakshmi to describe. So this is actually a demonstration what happens when a seizure occurs, and the parents will be panicking. And if you ask them what happened, even a medical person is finding it difficult to bring out all the semiological features just by watching a video once. Lot of points we can miss. So Dr. Rakesh will now tell us how a diagnosis of epilepsy is made and what are the points that we have to remember at this time. So how can we confirm the diagnosis of epilepsy? Rakesh.
Thank you, ma'am, for the introduction. Am I audible, ma'am?
Yes.
Actually, there is no definitive diagnostic test for epilepsy, but recording a video EEG for the clinical event can, to an extent, confirm the nature of the event. Especially when you have a clinical electrological correlate for that event, we can more or less confirm the diagnosis. But video EEG, as you all know, is not readily available everywhere, and also the technical expertise is not freely available. So in that circumstance, a detailed history will give you a proper throw a light into the diagnosis of epilepsy. So an accurate diagnosis depends on a detailed account of the events from eyewitness. When you don't directly take it from an eyewitness, when you pass the information from one person to another, the details get lost. So we may not be able to accurately diagnose the condition. So again, as you all know, obtaining a reliable history is very challenging, especially in our day-to-day practice, busy practice. We may not be giving enough time for getting information from the patients. So if you get a good history, it will be like visualizing the events as if you are watching that the video of that event. So when you take a good history, you ensure that you give ample uninterrupted time for the patient as well as the caregiver who is giving the history. Whenever you don't have an eyewitness directly coming to you, you make an effort to contact the eyewitness who may be a teacher or a friend via phone, so that you can get a first-hand information about the event. Also, when you take a history, focus on details like circumstances. For example, if a child is getting an event while blood is drawn from her, or for example, she's standing for a long hour and then getting an event, or those kind of events will throw light on what kind of events we are dealing with. Sometimes we may be dealing with a non-epileptic event. So these kind of circumstantial history will give you details, details on what kind of events we are dealing with. Also, when you ask for circumstantial history, you ask whether what the child was doing at the time, also whether the state of the child at that time, whether the child is in awake state or in a sleep, so that those all information will add on to the details of the history. Also, you can ask for triggering factors. For example, you can ask whether the event started with trivial trauma. Sometimes the child might hit his or head somewhere, and will start with that event will provoke a event. So that may be probably a reflex anoxic seizure, or there could be some visual stimuli that will stimulate a generalized tonic-clonic seizure. That could be a visual sensitive epilepsy. So those triggering factors also has to be asked for. And when you describe that event, ask for the baseline state, what the child was doing when the event started, and how the baseline status changed. And you have to describe in detail how the event progressed. Just like Dr. Lakshmi described now, you have to describe the event step by step, what change happened first, then how it progressed, so that you can get an idea of which all areas of brain is involved in that particular event. And also, when you ask history, you can start from open-ended questions. For example, you can ask, what do you feel when the seizure started? Initially, when you ask those open-ended kind of questions, the child might give vague answers, like I just felt dizzy or like that. So then as you move on with the history, from open-ended, you have to make a little more closed-ended questions. So you can give clues to the child, whether you can tell that, ask that, did you get an uneasy feeling in your tummy? Then child will say yes. So that will give you a clue that the aura could be probably a abdominal aura. Or you can ask the child what kind of, whether she was getting a wobbly kind of sensation in her tummy. So that will give you a more descriptive term for the symptom. So again, there will be a lot of confusion between a convulsive syncope or a generalized seizure, especially when the child is maintaining a prolonged upright posture, that even may be associated with a motor phenomenon like generalized tonic posturing or a generalized tonic-clonic seizure. In that circumstance, there could be a significant confusion whether are we actually dealing with a seizure or a convulsive syncope. So there are few points by which we can clinically differentiate whether we are dealing with a convulsive syncope or a generalized seizure. For example, in a case of convulsive syncope, there will be often there will be a trigger like a painful stimuli or standing for a long time. Those kind of triggers will be less likely in case of generalized seizure. And again, nature of trigger will be pain, fever, prolonged standing, or emotional outbursts, hot environment, exercise, or a Valsalva maneuver. Whereas in generalized seizure, it could be flashes of light in case of photosensitive epilepsies, or seeing patterns which can again present. And again, onset will be more gradual convulsive syncope, and usually will be sudden onset in generalized seizure. And duration will be very short convulsive syncope, which will be mostly.
Can you mute others, Gobi? Can you mute others?
And
ജിഷി മാഡം ബൈ മിസ്റ്റേക്ക് ഹോസ്റ്റ് ആയി എന്നെ തിരിച്ച് ഹോസ്റ്റ് ആക്കിയാൽ ഞാൻ മ്യൂട്ട് ചെയ്തതാണ്.
അതെങ്ങനെ ഞാൻ ചെയ്യണോ?
അല്ല, മാഡത്തിന് ചെയ്യാൻ പറ്റും മാഡം. കൽപ്പന മാഡത്തിനും മ്യൂട്ട് ചെയ്യാം, കോ ഹോസ്റ്റിനും മ്യൂട്ട് ചെയ്യാൻ പറ്റും. ഇപ്പൊ ജിസിയാണ് ഹോസ്റ്റ്.
അപ്പൊ ജിസിയോട് പറയാം. ജിസി ക്യാൻ യു മ്യൂട്ട് അതേഴ്സ്?
കോ ഹോസ്റ്റിനും ചെയ്യാൻ പറ്റും മാഡം. മാഡം ചെയ്താലും മതി.
ഞാൻ സാധാരണ ചെയ്യുന്നില്ല. ഓക്കെ, കണ്ടിന്യൂ.
And onset will be
sorry sir, continue.
Rakesh, please unmute and tell.
okay. Onset will be more gradual in case of a convulsive syncope, whereas will be more sudden in case of generalized seizure. And duration will be shorter in convulsive syncope and will be prolonged, lasting for minutes in generalized seizures. And again, prodromal features like lightheadedness, graying of vision, nausea, sweating, abdominal discomfort, palpitation, these things will be there in convulsive syncope. And in generalized seizure, they could have specific auras like tingling sensation, or there will be a racing abdominal sensation. And they can have focal or generalized seizures, and they may be also having associated automatisms. A tone will be usually flaccid or limp in case of convulsive syncope, and often in generalized seizure, the tone will be increased. But you can get a decreased tone in atonic seizures. Eyes will be usually open or partially open or rolled up in case of convulsive syncope. And generalized seizure, you can get an open eyes or staring appearance or sideways deviation, like in eye version could also be seen. And the skin color will be usually pale in syncopal attack. Whereas in generalized seizure, you can get either pale, flushed appearance or sinus appearance. And injuries are less likely in convulsive syncope and more likely in case of generalized seizures. And incontinence is more common in generalized seizures. Tongue bite is generally rare in convulsive syncope, and in seizures, it is more common, probably mostly in the sides of the tongue. And recovery will be prompt in case of syncopal attacks, and it will be slow in case of generalized seizure. Most often, they'll be having postictal confusion and drowsiness. The fact which will lead to confusion is the jerks, which are usually associated with convulsive syncope, especially if they are maintaining an upright posture for a long time before the start of the fall. They can have motor manifestations like jerky movements, but usually these jerks will be less than 10 in number, will be arrhythmic, myoclonic kind of jerks. Whereas in generalized seizures, the myoclonic jerks will be preceding the generalized clonic seizures, but those jerks will be more rhythmic and they'll be more than 20 in number. Can we move to the next?
Slides are not moving.
Rakesh, but I think most
Slide
important
has to be.
would be the provoking event, because many times if you have to ask child what you are doing just before that, like cutting a pencil or playing with a needle, or as you said, hitting the head by himself or herself. So those things, because both convulsive syncope and GTCS will have ultimately the tonic-clonic movements will be there. So the point by which you can differentiate is the definite finding out of this provoking factors. Okay.
GC, I'm not able to move the slide. Somehow something happened. So probably you'll have to again start screen sharing. It's not moving from my side.
Is it shared by you, the slides?
I was sharing.
Okay. In that case, the slides will be on the left side of the left lower part of the slide. There will be arrows.
So I can see, sir, but it's not moving. It is stuck. Now, can you see?
Yes.
Rakesh?
Yes, ma'am, I can see.
Okay.
Yes.
So one point I would like to stress here is that often we tend to ignore those children who are coming to you with epilepsy. But you have to make it a point that you take the history from the children as well. Especially when older children are coming to you, they'll be able to describe the symptoms, especially the auras or the premonitory symptoms, they'll be able to tell beautifully. So you have to make it a point that you get the history from children also. Younger children may not be able to exactly tell what they are feeling, but they'll be able to express those feelings what they are having through diagrams. This is one example. The first picture which you see on the left side is the description visual description of the auras which you get in Parentopaulus, actually drawn by children who experience these auras. The colored halos and the colored spectral patterns are drawn by a child. And then to the right side, there is another picture which is again described by a child who experience the semiology in a case of Rolandic epilepsy or the SELEX. So the child has beautifully described the facial deviation and ciliary, and also you can get important information from younger kids as well. So make it a point that you get as much as details from these children also, which usually we tend to ignore. So again, one point I would like to stress here is that, especially you are getting a child with probable childhood absence epilepsy, in your OP itself, you can make them do hyperventilation test to confirm it. In hyperventilation tests, you make the child do fast breathing, deep breathing for 3 minutes, or you can use a paper and ask the child to blow on the paper continuously for 3 minutes. Or when the child is doing this, they'll be stopping suddenly. They'll be stopping the activities which the child was doing for a few seconds. So that will be a bedside test to establish the diagnosis of childhood absence epilepsy. To this point, you can implement in your day-to-day practice. So another point which will give you relevant information on epilepsy is the home videos. It's a very valuable tool in diagnosis of epilepsy. Very low cost, can be recorded using smartphones because everyone is using a smartphone these days. But when you advise parents to record these videos, you have to tell them clearly that the priority will be for the safety of the child. You have to give the first aid first. And if you have enough people around, one of them can record these events. And when you record these events, when you give them advice for recording home videos, you can tell them they can practice recording these events. Like when event is not there itself, they can practice recording the child. And you tell them when you record the event, there should be ample light. If enough light is not there, we'll not be able to clearly see all the details. Also, you have to record from the start of the event till the end of the event. Otherwise, we will be missing important information. For example, the child will be having some terminal clonic jerks at the end of the event. That will tell you the localization of the epilepsy. So the event has to be recorded from the beginning to the complete end of the event. Again, if possible, high quality video has to be recorded, and that has to be told to the parent. And you have to tell them the importance of this home videos, especially if you're having a single semiology of events, a single video will be sufficient. Sometimes you will be dealing with an epilepsy syndrome where you will get multiple types of seizures or multiple semiologies of seizures. So you ask them to record all the different types of seizures so that you can actually diagnose what epilepsy syndrome we are dealing with. Or if the child is having a different kind of semiology, then you ask them to record those semiologies so that we know that there is a change in pattern of the event the child is getting.
So that may be sometimes a PNS or a psychogenic or a functional seizure also, isn't it, Dr. Rakesh?
Exactly.
So sometimes a child who is already diagnosed as having seizure may be having a non-epileptic event also in between.
Yeah. So those home videos will let you know whether we are dealing actually with a true epilepsy or a non-epileptic event. Some of the kids may be having both, like what Madam told, both epileptic as well as non-epileptic events. So if you have these videos, we can actually stop unnecessarily adding on medications or increasing the dose of medication. So that will help in therapeutic management also.
Okay, we move on to the next scenario, and this is for Dr. Jisi to answer. So, 14-year-old girl was brought with a history of dropping of objects held in the hands, especially in the early morning. This is followed by a generalized jerking for 5 minutes, and afterwards she has become drowsy for an hour. And this occurred on a day when she had a sleep deprivation. She had slept late on that day. Her mother and grandmother also have a similar history of having seizures from the adolescence, and also her EEG was done by a physician, and it was reported as normal. So from this, can we make out whether it is an epileptic seizure or a non-epileptic event? And another question is, can children with actual seizures or epilepsy have normal EEG? And can how can we increase the yield of abnormalities, picking up abnormalities from EEG? Over to you, Jesse.
Actually, from the previous description, Rakesh has given detail about how we take the history. From the history, we'll come to the conclusion whether it is epilepsy or not epilepsy, or in some cases, it will be uncertain whether it is epilepsy or not. By history, if it is confirmed, our next method is to look for EEG, because if you look without taking EEG, as we have seen the previous case, as Mini Madam has described, in that case, history was typical. Like there was initially some myoclonic jerk, there is dropping of pencil from the hand, followed by generalized tonic-clonic seizures, which is almost diagnosis of juvenile myoclonic epilepsy. But still, EEG was negative. That is the message I have to give. That is in around 1/3 cases, roughly around 1/3 cases, and exactly around 32 to 40 to 59% in children. First EEG after an unprovoked seizure may be negative. So normal EEG does not mean it is not epileptic seizure, because this epilepsy is a paroxysmal event. It may not occur 24/7. Okay, so sometimes it can be negative. And also electrodes we use, we do not keep over the base of the brain or on the medial surface of both hemisphere, we are not keeping. So it can be falsely negative. And also if the focus is deep as in insular cortex, by the time the signal reaches the scalp, it may get attenuated and it will be missed. So roughly around 1/3 cases, EEG can be negative, even if there is epilepsy.
So the parents of this girl request the doctor to get an EEG for her sister also, who is aged 11, to find out whether she has a propensity for seizure. So is it recommended, Jesse? So if there is already what you told was that if there is a clinical event which is suggestive of seizure, if there is a clinical event which is highly suggestive of seizure, you have to.
Madam, please unmute.
So you told that based on the clinical scenario, if there is a seizure, a history of epileptic seizure, then you look for order for an EEG. And if there is a from the history itself, you can make out that it is a non-epileptic event, not to go for EEG. So here is a case where from the history, you know that the child is having epilepsy, and the family, there is a strong family history also. So the parents now want to get a EEG done for the 11-year-old girl to know whether the child is having a juvenile myoclonic epilepsy, her sibling who is not yet had a seizure. So is it recommended, Jesse? Jesse?
He has to unmute, I think.
Jesse, please unmute
Yes,
yourself.
Yes. Even siblings of those with this JME, SELEX, they will have a genetic trait that sometimes there will be spikes in their EEG. That doesn't mean they require treatment. And as I've already discussed, on that cases of epilepsy, 1/3 cases it can be negative. The other way also, in those children without epilepsy, and in some cases we do EEG in case of non-epileptic events, like say in migraine cases. If there is some visual sensitivities there, some may do this EEG, and also some if there is reflex seizures, also some may do EEG. But if there is non-epileptic event also, in 1/3 cases there can be false positive EEG. That is, EEG can be abnormal in 1/3 of the normal cases also. And also studies have shown that in healthy children, around 5.6% cases, 0 to 5.6% cases, EEG can be falsely positive. So there is no need to do EEG for the sibling in the case discussed. Because as I've already discussed, because in some children, siblings of those with epilepsy can have a false positive EEG also, which is not relevant unless there is symptomatic epilepsy.
Unless there is a clinical seizure, there is no need to treat EEG or to confirm using EEG whether somebody has a seizure or not. Okay, so to whom should you refer to get an EEG done? Can you just refer to a lab and get it done, and then with that, can you refer to a neurologist?
It is better to refer to those who is really trained in epilepsy, because mainly the indication, maybe for unknown indication someone is doing, or uncertain indication. So proper history taking after it is confirmed that it is epilepsy itself. I think after that it is better to refer to a trained person in epilepsy. And even recording and interpretation of EEG of children should be undertaken by someone with expertise in child EEG and epilepsy, because many benign variants, maybe some brief sporadic spikes, or it may be simple artifact like simple tapping the child may show a spike-like discharge, which may be misinterpreted as a positive or abnormal EEG. So it is better to be done by a trained person. And when to do is the next question. That actually it should be done within 72 hours, because there is more chance of picking up abnormalities like spikes and postictal slowing during the initial 72 hours. If not possible, like if it is not possible, if EEG lab is having some difficulty, in that case, within 2 weeks, we have to take the EEG.
Often in our setting, it may not be feasible also practically, because EEG may not be available in all hospitals in every town or in remote areas. So you have to get an EEG done, and as you increase the number of times the EEG is taken, then if first time you told around 40 to 50%, and the yield increases once you do it repeatedly. So by the fourth time, more than 90% of the cases, you may be able to see some spikes or epileptic form abnormalities in EEG, isn't it?
Yes.
So what is the role of EEG in clinically confirmed epilepsies or epileptic seizure?
So so initially it is a supportive evidence. As we have told, it is a collaborative evidence. Will come to the conclusion that there is some epilepsy, and also further characterizing the epilepsy, whether it is focal seizure or it is generalized seizure. And next is regarding the pattern. If the particular pattern is there, we can come to the conclusion that it is, say, absence epilepsy or juvenile myoclonic epilepsy, depending upon the pattern. And also prognosis we can decide based on the epilepsy EEG pattern. That is, if the background is it is not like a normal child, we can at least prognosticate the patient that there is less chance of going to a normal child. Child may have cognitive decline, maybe some behavioral issues, sleep may be disturbed. These all things we can explain by seeing the EEG itself. And also we can decide the treatment, like in some cases, in the case of if it is specifically from one focus, whether to decide surgical management is required or not, or otherwise whether we are suspecting some structural lesion. In that cases, there will be some focality. So to decide the next treatment as well as deciding the investigation, EEG may be helpful. And one thing I have to discuss is that in some cases EEG may be negative, and as Minimum has told, we can repeat the EEG. Serial EEG taking will give a positive result, or in some cases sleep deprivation, as in JME, will give a positive positive EEG result, or in some cases sleep will induces seizures. So certain activation procedures will be helpful if EEG is not got an abnormal EEG, even after a positive history, and we are expecting a positive abnormal EEG, we can do some activation procedures as well.
What is activation procedure is we try to increase the recording of epileptiform event by some procedures in the lab, like doing hyperventilation, or if some pattern is shown, some children with visual sensitive epilepsy, they may develop seizures, or you can even make the child come with a decreased sleep the previous night, so that sleep deprived EEG, the chance for picking up abnormality is more. Sleep itself, stage 2 sleep, non-REM sleep itself is a time when more number of spikes can be recorded. So such activation procedures can be done to increase EEG. So at least minimum of 30 minutes EEG should be done in an older child with at least 15 minutes of sleep, and for a neonate at least minimum 1 hour video 1 hour EEG. If preferably a video EEG has to be done for a neonate with additional electrodes to detect whether it is actually a seizure or not. And I think Dr. Pradeep is there, our first year, the final year resident of MD Pediatrics. Pradeep, are you around? Pradeep? You were in the EEG lab 2 days back. No, so can you just, by looking at the EEG, tell us what is A and B? Just describe what it is. What do you see? Anybody else from the audience?
Slow. With slowing also is present.
The first one is showing a generalized spike wave discharge, which is classical of 3 Hz spike wave discharge of absence epilepsy. And the second one is a focal epilepsy. You can see synchronous as well as asynchronous spikes from the centrotemporal region. So the EEG helps you to tell whether it is probably a focal epilepsy or a generalized epilepsy that you are dealing with, even though some elements of focality may be there in generalized epilepsy also. So you can decide on medications, which we will come to later. Okay, thank you. Moving on to the next. Jesse, what is the role of neuroimaging, and what is it recommended in all cases?
And from neuroimaging, yes, in case of epilepsy, it is recommended. The role of neuroimaging is to look for or to confirm any provocative factors for seizures, like any underlying structural cause like focal cortical dysplasia or a space occupying lesion, or in acute cases, any hemorrhage, infection. It may also give further clue for genetic cases also, like in glutaric aciduria or in mitochondrial disorders, whether there will basal ganglion lesion will be seen. So as well as to guide the treatment, to inform the prognosis and to decide regarding the epilepsy surgery, neuroimaging is indicated.
Okay, so both in acute symptomatic seizures, imaging will have to be done, and in epilepsy cases, selected cases you'll have to do. Do you want to do an EEG in all cases, Jesse?
In all cases, except in genetic generalized epilepsy, like childhood absence, juvenile myoclonic epilepsy, generalized tonic-clonic seizure alone, and in this SELEX, in typical SELEX, self-limited epilepsy with central temporal spikes, what we call as Rolandic epilepsy. In these cases, these are MRI is not indicated. Otherwise, in all cases, epilepsy has to be done. That is the recommendation.
So you have already answered MRI is better than CT. Can you just elaborate on that a bit more?
Because MRI is mainly MRI is useful to find out the cortical lesion. CT is by CT we can exclude if there is hemorrhage or any calcified granuloma of neurocystic causes. MRI is better compared to CT because there is a better gray white resolution. Especially 3 Tesla MRI is better, which give a better idea of especially surgically removable FCDs or some drug-resistant epilepsies. 3 Tesla MRI will be better compared to 1.5 Tesla.
Tesla is a unit of magnetic field, field strength, and 3 Tesla is definitely better than 1.5 Tesla when you are contemplating on epilepsy surgeries especially. And when there is a drug-resistant epilepsy, initial MRI with the 1.5 Tesla is negative, you may be able to see better when you do a 3 Tesla MRI. So that was what GC was trying to say. So over to Kunju sir. So regarding the classification of epilepsies and epilepsy syndrome, how to identify epilepsy syndrome, what is the importance of detecting epilepsy syndrome, and what is the axis principle of describe in cases of epilepsy?
Are you hearing the medical test? Medical is producing a problem because here the temple.
Sir, Kunju sir?
I think are you hearing? Are you hearing? Because medical നടക്കുന്നുണ്ട്.
Yes, we can
കേൾക്കാം sir. കേൾക്കാം.
Actually, epilepsy syndrome, once you diagnose the 3 steps. The third step, that is the first step, is to exclude seizure mimics. Second step is to identify the seizure type. And third is identifying an epileptic syndrome. And a syndrome means a cluster of signs and symptoms customarily occurring together. So in this earlier we were classifying these syndromes in a different manner, but now we classify the seizure syndromes as structural, genetic, infectious, metabolic, immune, and unknown.
You have jam, yeah, jam, bread and jam.
And then we must be having a
Bread and jam, bread butter jam. That jam.
Please unmute him.
Sir, please unmute yourself, sir. Kunja, sir.
I am unmuting. Okay, so it is a syndrome where you can identify by identifying the seizure type, because as I mentioned, because epilepsy syndrome can have different type of seizures. Second, there can be two, because there can be abnormal EEG, which is very characteristic. Then third is the associated findings of the situations, if it is an age, is very, very important. So all these factors, when we consider, you term the seizures in a, whether it is an epileptic syndrome or a where simple focal or a generalized seizure. Okay.
So can you tell us what is actually a focal seizure and a generalized seizure? And focal epilepsy and generalized epilepsy, unknown epilepsy, unclassified, those terminologies is difficult for even.
You know that because generalized epilepsy, even though it is very much described, we all describe GTCS and other epilepsies, but generalized seizures are seizures where this can happen in a from the different regions of the brain in a simultaneous manner. But focal seizures originate at some point within and rapidly engage the other network. So this is the networking is very, very important. And then focal seizures usually originate within, again, networks limited to one hemisphere. But if it is spreading to the opposite side, then you will get a, earlier we used the term primary, because the primary seizure progressing to a secondary generalized seizure. But nowadays we use the term, the focal seizure evolving to generalized tonic-clonic seizure. So that is the terminology used for a generalized seizure that is happening following a focal seizure. Okay.
Okay, sir. So this is what sir was telling.
Mostly it will be absent seizures and motor seizures, and both the types, focal seizures and non-focal seizures. That means generalized seizures, you have both the motor and non-motor seizures. Earlier, at least I think our seniors like Padmanabh and all will be knowing the clinical diagnosis of epilepsy as a partial seizure and generalized seizure. These partial seizures were classified as simple partial seizure and complex partial seizure. In the complex partial seizure, you used to say that there is an impairment of awareness. There is lack of awareness and lack of responsiveness. Nowadays, because we don't use the terminology, we use the term a focal seizure with the impaired awareness. So if there is a focal impaired awareness seizure, it will be a complex partial seizure. And then both the type can have a motor onset as well as a non-motor onset. Because generalized seizures also has a motor onset and non-motor. Non-motor generalized seizures is absences, because absences, but absences also can be typical or atypical also. And then for everything, there will be an unknown onset, even if we have all the gadgets, as Rakesh was mentioning. Still, the origin may not be fully understood. Then I use the term unknown onset. Okay. You would have noticed the focal to bilateral tonic-clonic seizures, the lowermost. Okay.
So when even at the onset, from the onset we have some cases we may not be able to make out whether it is a generalized seizure or a focal seizure to begin with, and immediately which became generalized, in which case we till it could be unclassified also when you are not sure. So, sir has already explained all these things, and I'll move to the epilepsy syndrome also. Sir has already explained that it is a characteristic cluster of clinical in EEG features, often supported by specific etiological findings, and each epilepsy syndrome it has its own description by ILA, and it can be diagnosed in nearly 1/3 of the cases of childhood epilepsy. And what are the features? Can you just stress upon what are the features of an epilepsy syndrome, sir?
Actually, as I have mentioned, because it is one of the major classification system is by classifying these syndromes according to the age. And then earlier we used the terminology benign epileptic syndromes and catastrophic or malignant epileptic syndromes. But nowadays we don't use that terminology, but we use the term pharmacoresponsive epilepsy syndromes and pharmacoresistant epilepsy syndromes. And as we were mentioning, one will be the age. So age, that at birth to 1 year, 1 month, many times if you get an epileptic spasm before 1 month, whether it is a tonic seizure, then you may make a diagnosis of early infantile epileptic encephalopathy, or nowadays we use the term DEE, developmental and epileptic encephalopathy. Then all of you are aware of the infantile epileptic spasm syndrome. Don't get frustrated with that name. It is the West syndrome. So that happens between 6 months to 1 year. And then we have the Dravet syndrome. Then selects, because usually selects happens in the males of 7 to 12 years. That is a usual terminology in males, occurring after 1 or 2 hours of sleep, or in the early hours of early morning hours of the sleep, with the pictures we are showing. A gurgling sound may be heard. I think Ananda madam will be describing that, because she used to describe it way back in early 90s. So at that time onwards, we were all making diagnosis of a Rolandic syndrome. Madam is there?
Madam had joined, sir. Probably madam is around.
Yes.
Yes, madam. You used to describe that gurgling sound, because heard by the parents. When this Rolandic seizures starts. And
Yes,
then they have seizure, numbness, etc. Yes, madam. And depending upon the age, all other epileptic syndromes, because and the most important point is that you have to identify the comorbidities, because most of these seizures, because they are epileptic syndromes, even though the so-called pharmacoresponsive epilepsies like SELECT, they also may have identifiable cognitive dysfunction. That is where the terminology SELECT is used rather than the benign focal Rolandic epilepsy terminology is being removed, because we don't use the term benign, but we use the term their descriptive terminology. That is why. And so they would, why do you want to know a syndrome? Because you see, that Down syndrome was diagnosed some 100 years back, syndrome. But people understood it as a chromosomal anomaly after 100 years of diagnosing Down syndrome as a syndrome, where the people have described it. And so that is the advantage, because when you know it as a syndrome, at some point of time, you will get a clue for a etiology. Nowadays, it is more of a genetic epilepsies, but other points also may come in the near future, other than this genetic, because nowadays it is said that even though you get a genetic mutation, many times it may not be significant in epilepsy syndrome, because many will be having either an autosomal dominant, autosomal recessive, and they are all actually, even though you may say it as an autosomal dominant thing, actually it is a what do you call the de novo mutation. That's all. So, and this describe, I was telling about the BPNA, describe, where all the 4 steps or 5 steps, 5-axis diagnosis of epilepsy are incorporated in this BPNA's. So always description, as Rakesh mentioned, the description of the seizure. Then you have to identify whether it is because of the description, whether it is a epileptic or a non-epileptic event. If you identify it is an epileptic event, epileptic seizure, then identify the seizure type, whether it is a focal seizure, generalized seizure. If it is a focal seizure, whether it is a motor or non-motor, like that. Then you go for the identification of the epilepsy syndrome, because that will help in identifying the etiology, identifying the drug selections and other things. And then in all these steps, that is when you are doing the description, when you are doing the seizure type, all ILA recommends that you look for a cause, etiology in all these phases. When the earlier it was involved as an axis 4, but all the axis, that is 1, 2, 3, 4, because you know that whenever you are describing the seizure initially itself, you can look for some diagnostic or a etiological clue also, as a tuberous sclerosis, like that. Then the most important thing is the relevant impairments, especially as pediatricians. We are all social pediatrics people. So you must look for this impairment behavior, scholastic performance, family issues, because you must be careful when you are making a diagnosis of an epilepsy in an young girl, say for example, a 15 or a 16-year-old girl who is having a syncopal attack because she will be having her menstruation. Standing in the school, and helps a syncope. But it is many times I have seen that that girl was unfortunately diagnosed an epilepsy, and she is being labeled. So you know that once a diagnosis of epilepsy is labeled, because that the age is juvenile myoclonic epilepsy age. So nobody will have a courage to stop the seizure anticonvulsions also. So their life will go in completely, their marriage prospects definitely will be in difficult situations. I have witnessed a lot of people, many types of counseling I have tried, but these social issues will be there. Okay, so that also have to be.
So there are a lot of comorbidities, and for the holistic management of a child with epilepsy, we should know about the comorbidities, and also while prescribing the drugs also, and we should individualize treatment based on all these things. So what are the usual comorbidities that we come across in such children?
All of you are aware that one of the most important thing is ADHD.
So I am not able to hear you. Can others hear?
Okay, I think ADHD. And then this intellectual disability. And many times they may have a specific learning disability. Earlier, when we were giving phenobarbital as the main drug for the treatment, many children used to develop this sort of a learning disorder. But nowadays, because of that, we have reduced the usage of phenobarbital. Then as other associated psychological problems like anxiety, depression, you know that definitely those probabilities will be there. And bone health, because Dr. Mini has done an extensive research on bone health in seizures. And other, because admission to school, once a single episode of seizure happens in a class, then the teachers will say that, okay, you keep the child at home. We will give attendance, and we can bring the child for the exam alone. So that sort of a thing. And we have to press for the rule, that is the right to education. Because I have in number of situations, this right to education rule was quoted to them, and it was taken printout and given to many parents, so that they will be given a school admission. So all these things we have to think of.
Okay, sir. So, Dr. Rakesh, can you tell us about the general principles in management of epilepsies?
So when we are managing patients with epilepsy, first of all, we have to be certain that we are actually dealing with a case of epilepsy. So when you label a patient as epileptic, there is a chance that more than 60% of further recurrences in those children. So just like Kunju sir mentioned, we have to have a axis approach to these children. We have to have a description of the semiology of the event, whether it's epileptic or non-epileptic, the seizure types, seizure syndromes, and the comorbidities. Especially when you're having a diagnostic uncertainty, whether it is an epilepsy or non-epileptic event, make sure that you don't start treatment. You can actually wait and get a confirmation before starting the event. Also, I would suggest that don't label it as a seizure for evaluation. You can actually label it as a paroxysmal event for evaluation, so that the diagnosis can be open. The person who is seeing the child next time will go into details of that condition. So keep it open at that point of time.
You can continue, Dr. Rakesh, regarding the general principles.
Then the next question is,
yes, please.
You need any investigation prior to commencement of treatment. Actually, a very good quality, well-reported EEG is sufficient enough to commence anti-seizure medications. If you give it a good EEG, that is ideal. So what are the goals of treatment? So again, when you manage a child with epilepsy, the primary goal will be obviously the seizure freedom. But when you aim at seizure freedom, it should not be at the cost of the health of the child. So the child should not be having major adverse events. Again, different epilepsies will exhibit different kind of prognosis. So your initiation of treatment and the choice of drugs should be based on the kind of epilepsy we are dealing with. Again, we have to keep in mind a lot of other things when you're dealing with a child. For example, the child will be having academic issues. Repeated seizures may be affecting their scholastic performance. Their memory and behavior will also be altered if they are having continuous seizures. So those things also have to be kept when you choose the anti-epileptic medication and start treatment. So again, when you start treatment for a child, you make sure that their concerns are also taken care of, especially if you're dealing with an adolescent child. So the primary goal, as like what I told, is seizure freedom to attain with single or a minimum number of drugs. With no or minimum side effects, because we cannot afford to have a serious adverse effect, especially when you are dealing with a benign kind of epilepsy. Actually, there is no ideal anti-seizure medication. We can actually choose the medication based on the preferences we have and the concerns which we have. And make this point clear that these drugs which we use for controlling seizures are just anti-seizure medications. They don't prevent the primary pathogenesis, or they don't prevent the epileptogenesis. So when you start treatment for epilepsy for these children, you have to take the parents to our confidence.
Somebody is talking. Can the person who is talking unmute himself? Mute himself. It will be better because it is disturbing. One of the attendees is
Parvati is talking. Parvati. Who is Parvati?
Unmute all. Mute yourself. Attendees, please mute yourself. It is taking a lot of time because. Okay, Dr. Rakesh, continue.
To explain the parents the nature of epilepsy, as we all know, even if it is a simple febrile seizure, it will be like a nightmare for the parents. So when you are dealing with epilepsy, you have to explain in detail the nature of the epilepsy syndrome which we are dealing with. Both children as well as the parents has to be addressed. Their concerns has to be taken care of. So usually we start with a single drug. And when you start an anti-epileptic medication, you start with a small dose and slowly hike to the optimal dose. So when you do this kind of drug increment, you minimize the adverse effects like sedation, ataxia, double vision, or allergic reactions to these anti-seizure medications. And you have to keep this point in mind that the therapeutic level of a specific dosage will be achieved after 5 half-lives are over. So the medicines are not going to be immediately acting on child. It will take that amount of time for the drugs to act. That also has to be mentioned to the parent. And also you have to explain to the parent possible side effects. You have to mention the general side effects, or if a drug is having a specific adverse effect like Stevens-Johnson syndrome or a pancreatitis with valproate, all those specific adverse effects you have to tell in advance. Otherwise, if the child is coming with an adverse effect, they will question you that they'll tell you that you have not mentioned it in the initiation of therapy. Also, you have to tell them the risk associated with abrupt discontinuation of drug withdrawal, especially we are dealing with a barbiturate or a benzodiazepine like phenobarbital or clobazam. If you are tapering abruptly, they can have a bout of seizures. That point has also to be stressed to the parent. And also you have to tell the need for regular follow-up, and you have to mention where they have to contact for the follow-ups. And another important point is the maintenance of a seizure diary, where they have to write in detail the seizure date, number of events, as well as the semiologies, so that we get an idea of how to taper the drugs and whether the seizures are getting controlled or not. And also we have to tell them do's and don'ts during a seizure, like what all things to be done during a seizure and what all things not to be done. And also you have to mention the first aid measures and what treatment has to be given before reaching the hospital. And also you have to keep in mind the drugs which can aggravate certain types of seizure. For example, if you use carbamazepine or oxcarbazepine, it can aggravate myoclonic seizures. Also, lamotrigine and vigabatrin can aggravate myoclonic seizures. Also, you have to take in consideration the comorbidities of a child. For example, if you're dealing with an obese child, try to avoid valproate. And if you are dealing with a child with ADHD and behavioral issues, try to avoid benzodiazepines and phenobarbital. And again, children with psychiatric issues, levetiracetam, perampanel, and brevacetym has to be avoided.
So to Jisi, thank you, Rakesh, for that excellent presentation. To Dr. Jisi, Rakesh was mentioning regarding the first aid measures and pre-hospital treatment. So can you highlight on that? Jisi? Dr. Jisi?
Okay. So the initial 5 minutes is very important as far as epilepsy is concerned. So first aid should be done, as you all know, we have to loosen all clothes, make the child lie down in a lateral position or the recovery position.
This is for the GTCS, no? For the focal seizures and all, it may not be really important. For the GTCS, that is what Dr. Jisi is telling. Okay, carry on.
And after first aid is done, even if it is not controlled within 3 minutes, our next step is to give midazolam spray if it is available. The importance of this time is very important, because after 5 minutes, it is unlikely to seizure to stop by itself. So initial 5 minutes is very important for the control of the seizures. And within 5 to 30 minutes, it's also important. And before that, how to use this spray. I think now all hospitals are using this spray. This is midazolam nasal spray. There is we can hold the nasal device with the plunge, and there's a plunger, and with the middle and index finger, we can hold the nozzle. And after placing it in the nostril, we can just press the plunger firmly. But before that, you have to make the child lie down in a 45-degree position, 45-degree head up. And before pressing, before giving the midazolam spray, you have to prime the midazolam spray. That is, you have to press it 2 to 3 times, so that the liquid is well given to the nostril. So the doses you can give 0.2 milligram per kg. By if you press once, we will get around 50 microgram. So for a 10 kg child, we can give 4 puff is enough. So initially you give to one nostril, and then to the next nostril. Then you can keep the wait for some time so that it absorbed, and again you can give the next again to the opposite nostril and to the other nostril. And if it is not controlled by that time, it is better to take it to the hospital. And other indications for immediate transfer to the hospitals are if you are suspecting some injury, or if there is any fluid vomit in the mouth and there is chance of aspiration, if seizures occurs in water, the child has breathing difficulties after jerking stops, or if there is a jerking stops and again there another seizure develops, and if it lasts for more than 5 minutes, it is better to transfer to the hospital. And there's importance of this. The T1 is the time beyond which the seizure does not stop by itself. And after 30 minutes, T2 is 30 minutes for the GTC. Generalized tonic-clonic seizure, T1 is 5 minutes and T2 is 30 minutes. And importance of 30 minutes is after 30 minutes, there is chance of neuronal injury, and there will be further consequences. And it is during that time that cerebral autoregulation fails, and there is all chance of further consequences and neuronal damage.
The next is to Kunja sir. Sir, a case of epilepsy is diagnosed. It's not an emergency. We have just diagnosed epilepsy. So, how do you select the most appropriate anti-seizure medication? Rakesh was telling the general principles. We have to select the most appropriate one. So, Kunja sir, what is the most appropriate anti-seizure medications? How do you decide? Kunja sir?
Okay, certain practical aspects also we may have to consider. For example, in hospital situations, for example, in SAT, we usually try to give those medications which are available in the hospital, or sometimes there and depending upon the age also, because different drugs may be useful for same type of epilepsy. So it may be a selection bias by the epileptologist. But anyway, the common seizures, and what I will usually say that for a pediatrician, if you have made a definite diagnosis of epilepsy, and you know that whether it is a generalized seizure or a focal seizure because you cannot identify it, then you may go for a sodium valproate, because earlier we used to say that sodium valproate is a drug which will be useful only for generalized seizures. But we now know that it can be useful for a focal seizures also. So if it is controlled with your sodium valproate, which usually we start with 20 milligram per kg, then that is okay. But then uh, uh, depending upon the situations. For example, earlier we used to give valproate in all children with juvenile myoclonic epilepsy, because myoclonic epilepsies and JMEs, again sodium valproate is the best drug. But problem is that the sodium valproate pharma company themselves are giving us a warning saying that the children above 12 years should not be given valproate. And so they are giving that warning so that they are taking their responsibility from the drug, and then they are transferring the responsibility to us. So since we don't want to take the responsibility of development of menstrual irregularities, polycystic ovarian syndrome, and again when a mother becomes pregnant, you know that various congenital malformations that can happen, like neural tube defects. So in such situations, definitely we will not use valproate. So what are the drugs then it can be used? But like sodium levetiracetam, or sometimes we may use lamotrigine. These are the drugs being advised by the both the international actually the drug selection is by nice guidelines it is there they are giving these guidelines. And then most of the day has seen the neurologists themselves giving most of the drugs in a thrice daily manner, because they give thrice daily, and because parents has to give it the drug at in the school also, because almost all drugs has got anti-epileptic drugs has got a half-life of more than 12 hours. So definitely a BD dosage is enough, and there is no need for giving it as a thrice daily dosage, because if thrice daily dosage is given, then you know that there's a school their school performance will come down, and definitely the default also will be more. And then because especially many has categorically mentioned that when we are using a phenytoin, especially in children with the intellectual disability, a possibility of a gum hyperplasia can happen. Earlier, again, it was a very big issue for all of us, but nowadays it is less, because less usage of phenytoin, and the children, the oral hygiene has become better, because nowadays people are all using the toothpaste, and because of that, definitely the gum hypertrophy that is happening is less.
Issue is that, sir, when syrup preparations are used, especially on daily basis, many of them, when they don't clean the teeth and gums after that, or give some water to drink after that, I have seen children developing caries tooth, and that's a major issue. So that was why I was asking. And also one more point to add, sir, sodium valproate, even though you told that it is easy to start, in children less than 2 years, what is your advice, sir? Is it better
Actually,
to
it is,
have a caution on using of sodium valproate in smaller children?
it's better that we can start with levetiracetam, because I opted for a valproate because of the price, but the levetiracetam would be definitely a good choice. Where again, just like broad spectrum anti-convulsants, like valproate, levetiracetam is also definitely a broad spectrum one, so it will be useful. But I think children above 1 year also we can give sodium valproate, not much issue. But below 1 year, definitely you should not be given, because the chances of hepatic toxicity is very common. But again, even though those are the Western recommendations, what I have seen is that in Indian scenario, the sodium valproate toxicity is not at all seen. When I was in States for just 3 months, I saw at least 4 or 5 cases of valproate hepatotoxicity. But in all these years, I just witnessed one case, but ultimately that case also turned to be a infective hepatitis. So it is very rare to have but maybe a transient increase in the SGPT or other transaminase may be there. Otherwise, it doesn't produce true hepatotoxicity.
So if the first drug fails, what should we do, sir?
Okay. So what will you do? Because ideally speaking, you have to start tapering the first drug in a slow manner, and we will start the next appropriate manner. For example, as I have mentioned, by this time, you should characterize the epilepsy seizure type and seizure syndrome. So if it is a focal seizure, definitely we will go for oxcarbazepine. Nowadays, I all prefer oxcarbazepine. Again, the dosage will be 20 milligram per kg. Unlike carbazepine, the development of Stevens-Johnson syndrome is very less or very rare. So for a focal seizure, you can go for this thing. And if you have started Boxetol or oxcarbazepine as the first drug, then you may go for other drugs like phenytoin, or again lacosamide, lamotrigine. All these drugs can be used. But only thing is that ideally, once you know that your first drug has failed, people will have a tendency to continue that drug also. So our aim is to have ideally we have to have a monotherapy. But again, see, whenever we have the science coming in and the specialization increasing, there will be a rational polytherapy is being described. And so the neurologists are nowadays going for again for a polytherapy, but they will say that a rational polytherapy is being advised. But my advice is that you may go for a 2-drug, because first 2 drugs combination. First drug you give, then no improvement, you taper and stop. Then go taper and stop means along with that newer drug has to be started. And in spite of the second drug also, if they get seizure, we can add another drug. In this case, we may keep the previous drug also. And if the seizures are improving without any recurrences, we may try to taper the other drug which also did not give much improvement. Then there are certain situations, for example, absence seizures. Because absence seizures, edoximide is available in our country, so it can be used. But I have seen that at least some 30% of cases of absence seizures may not respond to the edoximide. But in such situations, either you may give sodium valproate again or lamotrigine. But usually the better. So in this case, because a combination of sodium valproate and lamotrigine will give a synergistic effect, because a small dosage, addition of a small dosage of lamotrigine will reduce the seizures again in a dramatic manner. So that synergism is definitely is clinically demonstrated. Then there are all other add-on with the synergistic effect and another mechanism of action, like because clobazam is one drug which is being used as a add-on drug, as a second drug, because before converting to a newer drug and tapering it, because clobazam definitely may be a helpful drug as a drug when the initial drug doesn't respond.
Just adding on to what sir told, if one drug fails, again, at each point you'll have to consider whether it is an epileptic seizure or a non-epileptic event, and whether there are any coexisting or functional seizures, which has to be considered, and whether your choice was appropriate for the type of seizure, whether the correct dose and frequency you have administered, is the patient compliant, are there any drug interactions which drop the level of the drug? After considering all these things, if you feel that your choice was correct and the child is compliant and taking adequate doses, then you go on to the second dose and try to come down on the first drug, or you can add on 2 drugs if it remains unresponsive. So that was what sir was previously telling us, drug responsive and drug resistant epilepsies. So what are the adverse events that usually come across while treating with the anti-seizure medications, sir?
Yes, I mentioned, because I usually give a tip for side effects. The classical or earlier drug, where you can think that each drug may have a complication of each system. Like, for example, generally all these drugs can produce a sedation, double vision, fatigue, confusion, etc. And then the most important point that I usually tell to my students is that because each drug, for example, as we have mentioned, CNS complications will be more with the phenobarbital, along with the hyperactivity and the specific learning disorder. Phenytoin will produce hematological complications and lymphadenopathy like that. So hematology complications. And then carbamazepine will produce skin complications and granulocytosis, again hematological complications. And then sodium valproate, it will produce a hepatic involvement. So that means you have to think of each system being affected by the drug. And renal, earlier there was no drug which were producing renal complications. Now we have a drug which produces renal complications, that is topiramate, because if the child or the adult doesn't take water properly, then there is a chance of development of renal calculi, stones. So that means the chance of developing renal complications. Okay, and bone and other complications like bone pain, and many children who are kept indoors, they will develop a severe vitamin D deficiency, and so such things. And pre-existing conditions very, very important, like liver disease, renal disease, and other things. Adolescent girls, already we have mentioned about avoiding sodium valproate and usage of levetiracetam and lamotrigine.
So in case of renal disease, those which are not being excreted through kidneys, that is a choice. And those which are excreted, levetiracetam is excreted. That is one which we commonly use, topiramate and lacosamide. So we'll have to consider the GFR and adjust the dose and the frequency. And also liver disease, as sir already mentioned, those which are having metabolism in liver, those drugs like valproate, phenytoin, phenobarbital, carbamazepine will have to be used with caution or should not be used in such a situation. Levetiracetam will be better in such a situation. We have to monitor the LFT and RFT in such patients very closely. Now, we have already late, so I'll skip these 2 slides and then we'll go to follow-up of these patients. During follow-up, what all things we'll have to see, sir?
Follow-up, because a regular follow-up,
because this is very important. We may not be seeing, the pediatricians may be seeing, and so what all things to be considered while the child is being followed up by a pediatrician?
And foremost, there should be a regular follow-up, because many times we may say that this child requires anticonvulsants for 3 years, and they will listen to that in the OP and will just disappear, and they may come after 6 months or 9 months having the next seizure. So, so it should not be happening. So we must have a fixed consultation time. Usually, it is better to have a 3-monthly consultation. And so, if in that you know that you have to look for a seizure frequency, and most important need for the follow-up is to look for adverse events. Because again, rather than doing a very routine examination of liver function test every other 2 weeks, it is not at all required, because when liver toxicity is produced by sodium valproate, there will be clinical symptoms. So in the initial phase, there is no recommendation for a regular LFT examination in those patients who are receiving sodium valproate. But you must be careful about it and ask for a vomiting, loss of appetite, and such things. And then already I have told you that, because sometimes they may have comorbidities like this you have to notice earlier. It's a hyperactivity, because nowadays I am seeing that hyperactivity is a norm for most of the children. So you have to identify while you are starting the drug itself. But if it is there, then you can tell them that see, when I started the medications, he was having it. But nowadays with a phenobarbital or a levetiracetam, there can be some amount of hyperactivity or a behavioral disturbances. So this also we have to look for. SUDEP is not, because again Rajesh Ravindran is a person who describes a lot about SUDEP. But in Indian scenario, because we all keep our especially a child with a disease along with the parents, the chance of developing a SUDEP is very rare. But then vitamin D supplements again depends upon the earlier, because we can do a vitamin D measures, or every 6 months we can give vitamin D, because the measurement of vitamin D itself is costlier. So if you give a vitamin D 6 weeks dosage, that will be sufficient. So that way it can be monitored and managed.
To add on, if a child omits within half an hour of taking an anti-seizure medications, it is better to repeat the dose, and also to continue the anti-seizure medications without fail during intercurrent infections, because sleep deprivation, fever, these things can provoke seizures in already children with the epilepsy. So this is very important. They don't miss their anti-seizure medications. When too many drugs are being given, they may skip the medications. This medication will be skipped, and they will give antibiotics and paracetamol, but parent will not give anti-seizure medication, so patient will throw a seizure. Also, anti-seizure medications should not be adjusted unless there is a adverse event during any acute illness. So it has to be continued if already the child is well controlled with that. And vitamin D supplements, it's a regular supplement we are advising, sir, not the mega doses. Usually 400 units regular dietary intake is there. So a bit 2 to 3 times more of that, especially if they are on enzyme-inducing drug. That is what is recommended by the NICE guidelines and all. So that was what I was mentioning in this slide. Okay, sir. How to stop the anti-seizure medication, sir? When to stop it?
So it depends, because usually because in general, we'll consider anti-seizure medications withdrawal if one is having a seizure-free period for 2 years. But again, these factors depend upon the seizures that has occurred before the control of the seizures. Suppose one person had seizures very frequently, maybe for last 4 years, every year or every 6 months he is getting, but the last 2 years there is no seizure. If you are going to stop that seizure in 2 years, they will develop definitely seizure, because they are not ripe enough to get the AFM withdrawal. And another situation is that because in certain situations I may use to stop even at 1 year also. 1 year also, because child had only one episode of seizure. It was a short-lasting seizure, and previous to that nothing was there. And EEG also was showing whether real abnormality or not. In such situations, definitely we may try a stoppage at 1 year also, after 1 year. But only thing is that
Sometimes in self-limited epilepsies, sometimes even if they are very brief nocturnal seizures without GTCS, one may even go without a anti-seizure medication. Also, parents may prefer that in some cases. That is what Westerners do usually. And also in self-limited epilepsies nowadays, it is said that you can withdraw after try withdrawing after 1 year, or if the child is in the adolescent age group, like 12 years and all, you can start withdrawing the traffic even if the EEG is abnormal, because it may take the EEG to become normal. EEG will remain abnormal till 16 to 18 years in such children.
If it is a complex partial seizure, definitely, see, in all seizures, actually you must give a chance of stoppage, but only tell them that because we are giving a chance of a stoppage for the patient, but there is a chance of recurrence almost 30% after the stoppage. So if it happens, then you can advise them the recovery measures, and then ask them to come back so that the drug has to be done. Because this strategy I have used in JME also, because you know that again the girls, if you are continuing the anticonvulsants for lifelong, then again you must know how their life is going to be. That is the most important point to be remembered.
Okay. And now moving on to the last few slides, Dr. Rakesh, Kunja sir has already explained whether it is needed or not, but still to highlight it, whether CBC and LFT has to be done at regular interval, and do they have any other issues, like while if you are testing thyroid function test or cholesterol, do you see any abnormalities in patients with anti-seizure medications? Rakesh?
Generally, we do not have to repeat a complete blood count or LFT at regular intervals. And the clinical indication to test CBC includes development of a sore throat or a bacterial infection. Actually, if there's a clinical event, then you can actually just check for complete blood count. Or if there's a new bleeding or bruising or excessive fatigue, you can check it. Or if you're, especially if you're starting or increasing a dose, you can check it. And again, for indication, regular indication of LFT is not required, just like what Sir has mentioned now. If there is a clinical indication, like a feature of encephalopathy, like confusion, lethargy, or drowsiness, after when you start the medicine or increase the dose, then you can do an LFT. Mild derangements of SGPT or OT, that is, if it is less than double the upper limit of normal, that is not of major concern, unless the child is symptomatic. If the child is symptomatic or the clinical status is deteriorating, then probably you can repeat the test. And again, this point Sir has already mentioned, if the child is less than 2 years, you have to be careful while a child is on valproate. Or
seems 1 minute, Rakesh. Dr. Rajesh wants to leave. Just before he leaves, I'll just invite him to comment on SUDEP. What is his experience? He has extensively published on SUDEP. So Rajesh, what you have to advise? In Indian scenario, I have a practice of co-sleeping. So in which kind of patients is SUDEP more common, and do you have to advise the parents regarding SUDEP? What is your feel on that? Rajesh? Rajesh? Probably he has left. Rakesh, you can continue.
Yes, left.
See, one more point I just wanted to highlight is the 2 points. One, always think of an acute pancreatitis in a child who is having receiving sodium valproate, because I have seen our pediatric surgeons operating for acute appendicitis for a child acutely. Then next day only they will identify that the child was having on sodium valproate. So then the serum availase will be done, and they will find that there is a acute pancreatitis when they refer to us. That is why any child who presents, any child on sodium valproate, he develops an acute abdomen, you have to the serum amylase. Second, again, the thrombocytopenia of sodium valproate is also another issue. So again, especially when you are giving a consent for surgeries, there again you ask for a platelet count, which usually nowadays people are doing it as a routine thing. But you must mention that, because one of the known complications of sodium valproate.
Since our IAP president is here, we would like to get his feedback also. Rakesh, what is the problems with testing TFT and the lipid profile, and what is the derangement that you see in and while on anti-seizure medications?
So again, some of the anti-epileptic medications like carbamazepine, phenytoin, valproate, phenobarbital can have effect on the thyroid function test. Mostly they'll be causing a elevation in TSH with low values of free T3 and T4. Most of the time it will be a subclinical hypothyroidism, which actually doesn't require any treatment. But in some scenarios, that TSH level might rise above 10 with symptoms, then probably we'll have to treat those conditions clinically. Again, certain anti-epileptic medications can have an effect on the lipid profile also. So again, there are no actual guidelines for how to go about in these cases. More studies are required for more details on the management of these scenarios.
Okay. So, Jisi, we are coming to the last few slides.
1 minute. Rajesh has re-entered and you just call him.
Rajesh, can you highlight what is the significance of advising on SUDEP, especially in which kind of patients is this common? And in Indian scenario, we do not come across many cases of SUDEP. Probably the parents are co-sleeping with children. And then in Western scenario, the condition is different. So what is your take on that? So in which kind of patients do you see SUDEP more? And is there any need to advise on SUDEP? You have been working in India and across abroad also.
So SUDEP is sudden unexpected death in epilepsy, which is a reality. And I don't think that epilepsy and SUDEP in India is anyway different from SUDEP and epilepsy in North America, except for the etiology of epilepsy. Because you might find more hypoxic ischemic encephalopathy as an etiology or an infection. The rest of the course of epilepsy and the mortality, in my opinion, is the same. You describe SUDEP in terms of patient years. So if you have 10 patients, you follow them for 10 years, it is 100 patient years. Risk of SUDEP in a garden variety of childhood epilepsy, irrespective of the severity, is 1 in 10,000, which means if you have 100 patients or 1,000 patients, you follow them for 1 year, you are going to lose one child. When it comes to drug-resistant epilepsy, which is the term we use, the risk is as high as 1 in 100. That if you follow 1,000 patients, I am sure that you will have massive population with drug-resistant epilepsy. If you follow 1,000 patients for 1 year, you are likely to lose 10 patients to SUDEP. When I present this for the past decade in India, people always say that, well, none of my patients had a SUDEP. I think I hear you, because in how many of them you have the real follow-up. So Mary Ibe, during one of the last sessions, she said that probably because there is no structured follow-up. I agree with Dr. Kunyu that one of the factors that might be protective is immediate resuscitation. So if there is a child is co-sleeping with the parent, probably there can be a stimulation and there can be less incidence of SUDEP. The importance of counseling about SUDEP, one thing I always say is, it is not to scare the parents. It is to actually provide them reassurance, saying that this is a very rare condition and that many parents lose sleep because they fear that during a seizure, their child is going to die. And the risk of death during a typical seizure is extremely low. And if they go to Google and all the social media, they find information about SUDEP. So the purpose is to reassure them, but at the same time, they should have a realistic expectation, because if something untoward happens, I think they should not regret that they were not informed earlier. So for me, I discuss SUDEP with all my patients, including absence, because we know that about 12% of childhood absence epilepsy patients develop generalized tonic-clonic seizure in the second decade of life, but in a non-threatening, reassuring manner. But I have the luxury of seeing that patient for first consultation 1 hour and the follow-up 30 minutes. Do you have that luxury? So I can preach that all of you should discuss, but if you are seeing the child for 10 minutes, is SUDEP your priority? I think your priority is to ensure that they understand what epilepsy is and how they should follow up on the management plan. But based on my research and recommendation from the professional societies, it is that we need to discuss about SUDEP. If you are a novice starting to discuss about SUDEP, I recommend that you start with people who are not drug compliant. The second is teenagers who are very resistant to take medication, then teenagers who engage in high risk behavior, or people who have really drug resistant epilepsy. That is a group I focus. Plus, if the mother is crying in your room, explore a bit more. Usually she is afraid and you can reassure. But the way I practice is, including absence, I give reassure them about SUDEP. People always say, "What about self-limited epilepsy with the centrotemporal spikes, previously known as benign romantic epilepsy?" There are at least 3 case reports from the North American registry who had this particular condition and had a SUDEP, and especially there is a nocturnal seizure. So it is highly contextual. My research is probably not applicable to all cultural and geographic regions, but this is a fact, and that is not uncommon. When somebody is dying, you cannot just say the name, it just happens. So if there are any questions, I am happy to answer, but I don't want to too much lecture on SUDEP.
Thank you, Rajesh. Thank you for those valuable comments. We will move on from SUDEP to the rest of it, 1 or 2 slides more. Dr. Jisi, is there any need for a lifestyle modification in patients with epilepsy, especially adolescents? And is there any need to restrict them from participating in sports, NCC, etc., etc.? Jisi?
There is no need of overprotection in these children, and also there is no blanket restriction of all activities. Adequate sleep is essential for about 7 to 8 hours per day, and it is better to avoid alcohol and also this drugs which are enzyme inducers in most of the cases. And also visually sensitive epilepsies, this especially while doing video games or for attending the DJ, they have to be they have to do with caution, because many epilepsies can be precipitated, like JME and occipital lobe epilepsies can be precipitated. So nowadays goggles are available to protect against that.
And what about participating in sports? Any recommendations on that?
ILA has given a recommendation based on that. That is, they have divided it into group 1, 2, 3 based on the risk. That is, in group 1, there is no significant additional risk factor to people to epilepsy or to bystanders. That include mainly the athletic. They can participate in all athletic games, basketball, dancing, and routine playing. Means that is okay. For the group 2, there is moderate additional risk to people with epilepsy, and there is no additional risk to bystanders. In group 3, there is risk to bystanders as well. And that way it is divided. And main thing is that the physical activity should be recommended unless there is tendency to develop seizures.
There is a risk for the patient as well as the persons nearby, especially in those motor sports and all, bike and car racing and all. Those are activities that is for the adolescents mainly. And for younger children, we have to recommend usual participation in school sports and all. Not, is it not? Okay. So, Ananda Madam, Kalpana Madam, and others in the attendees, Srinivasan Sir, Parvati Madam, any comments?
I have given that comment that there's one single episode of seizure, patient comes and short-lived, EEG is normal, then what do you do? I usually advise them to wait for, if seizures recur, then we can start AED. But abnormal, then I start the medicines.
That is the operational definition says, madam, if there is a single unprovoked seizure and more than 60% chance, there was a study which was analyzing the
seizures later on.
So if there is a focal deficit or MRI structural lesions, and if you feel that there is a chance.
Everything is normal. One single episode of seizure.
Yes. That will be the lowest.
Everything
So
is
there
normal,
the
but one
recurrence
single
is not
episode of seizure.
60%. So what madam
If
is
it is
telling is
prolonged,
absolutely correct.
if it is prolonged, if the child had a status, then you have to start.
I'm not saying the recurrence chance is 60%. What I'm saying is that if the recurrence risk of recurrence due to additional risk factors is same as a second episode has happened, then there is a chance that 60% will have recurrence of seizures. That is the MES study. So based on that 60% this has come. So if there are additional risk factors, one may discuss with the parents, and then based on the discussions, we may start, or you may tell them the first aid measures and the rescue measures, and then wait also. It's depending upon the case, individual case.
Yes. That's all. Okay. The discussion was very nice. The slides were nice. Thank you, Dr. Kunyu, for coming.
Thank you, madam, for joining.
A lot. Thank you.
Thank you, madam.
Okay.
Thank you.
Because of the power cut here, I am not able to open my video. So question answer session, can one of you just see whether there is anything?
There is no questions as such. Actually, there is.
If there are any questions, we can discuss also.
You can unmute and ask if there are questions.
Attendees can unmute and ask.
And
Still
any
there are
comments also from the senior teachers.
And I want to add one thing, that is regarding this midazolam nasal spray. The midazolam nasal spray is available in 0.5 only, is available now.
Yeah.
So a 10 kg child needs 4 puffs. A 20 kg child needs 8 puffs. And maximum dose is 20 puffs. And according to the that is how you should give, is actually you should give 1 puff and wait for 1 minute and give it to the other side. If that is being practiced, that will not be useful at all, because it will take so much of your time. So what I can say is,
madam, earlier it was no, and then midasip and all, we used to give 1 puff into each nostril for 5 kg. For each 5 kg, 2 puffs.
That is the
now
thing, 5
it was
kg 2, 10 kg 4. So what I am telling is, if we are giving 1 and then the next one, if you are giving after 1 minute, and then even in a 10 kg, it will take like 4 minutes. Even a bigger child, this is actually like not useful. So what I'm telling is, nowadays this intramuscular midazolam is mentioned, which can be done in pre-hospital or in the primary health center everywhere. You can give the midazolam 0.2 milligram per kg as an intramuscular injection when the child is coming from with seizure. So
Madam,
that is very, very easy. Even in the ambulance you can give.
Madam, actually for that we have to teach the parents how to.
No, this is not parent. Pre-hospital when the child is in ambulance.
In the ambulance, the person will be there.
No, not for the home care.
Seizures are very frequent.
Not for the caretaker.
Okay.
Yes, when the seizures are very frequent, even if you can teach the caretaker if they are very knowledgeable. Otherwise, in any PHCs or anywhere or in the ambulance, it can be used. The other one, this midazolam nasal spray, what I see is they give 1, 2 or 3 puffs and then will say it is not controlled. And so it is not used. When western part, it is like 2.5 milligram per puff, and which are being used, and 1.25 milligram was introduced, but there were so many problems and it could not be continued. So midazolam nasal spray, it is better if you have an IV line, better to give the lorazepam or IM midazolam. That is what I am telling.
Sometimes you'll have to just pre-test and by just pressing and seeing whether it is coming.
Yes, many a time it is not coming also.
So first you have to test on your hand whether it is coming or not. And if you hold it sideways, sometimes it doesn't work also. Slightly upright position, the thing will work, because I have used it for my child, I know. So
with the
there is some difficulty.
Most of the time it was not working, and then it was actually banned. It is not coming.
Yeah.
It must be vertical.
Yeah, vertical. That is what
is very important, and child should be
was telling. Child's head has to be slightly up while you are giving. Initially, left lateral position, once you are giving this, slightly the child has to be turned and then the head should be slightly upright so that the spray can just reach the roof of the nostrils.
Yes.
Yeah.
Yes.
But
Be
the
vertical.
number of puffs is what I advise practically is you can press 2 times. So 2 puffs at a time and to 30 seconds interval, I will give it to the opposite nostril so that the time can be adjusted. But that is not a recommendation.
Okay, because it is said that if you alternate, there will be time for absorption from one nostrils, then you go to the next, there it will be absorbed. If you come back to the first, it will be absorbed. But the problem is if there is URI and all, if the nasal secretions are there, sometimes it may not get absorbed well also. So there can be issues also. Any other comments? Riaz, you want to comment on the thyroid function and the treatment regarding that? Have you come across obesity and cholesterol and all those things, endocrine issues? Riaz?
Madam, one more question that is regarding this hyperventilation bedside. I couldn't hear properly. The hyperventilation bedside test for hyperventilation.
നമ്മൾ ഇപ്പോൾ ഇച്ചിരി ഒരു ഓൾഡർ ആയിട്ടുള്ള ചൈൽഡ്, ഒരു 4 to 5 years old child.
Yes.
ഒരു പേപ്പർ എടുത്ത് വെച്ച് ഊതുക, പേപ്പറിന്റെ ഫ്രണ്ടിലോട്ട് നന്നായിട്ട് കുറെ നേരം ഊതാൻ പറയുക, അറ്റ്ലീസ്റ്റ് 1 minute.
Thank you.
Okay, Dr. Ranjit Govindan. Dr. Ranjit, do you have anything to ask? The hand is
No, I was just I work in the UK and I was just listening to this really informative talk. I just want to comment on Kalpana Madam's very valid point that she made regarding the buccal the midazolam. Here in the UK, we use buccal midazolam, which there is no nasal spray, and as you said, it's not something that cannot be used, something that can be used in a multiple puff fashion. So it's a blanket dose for age banded. So here we use, it comes as a preloaded syringe, and 1 to 5 years of age, it is 5 milligram. 5 to 10, it is 7.5 milligrams, and above 10, throughout the rest of the life, it is 10 milligram. And parents are allowed to use only one dose. A second dose can be given by paramedics. The entire healthcare setup is different, but teaching the families is not difficult, particularly in Kerala.
But it is not available here.
No, I know, but I know Riaz is there. There are very powerful people there. So the pharma, everything is manufactured in India, and it can, if you tell pharma from from a point of position of power or authority, I think this can be sorted.
Years back, our intensivist Dr. Sajid has done a study on the buccal midazolam. We used to use that vial which is opened and it was taken in a syringe and was pushed. We were pushing that, and it was very useful actually, definitely. But the thing is, we cannot use that for the general patient or in the pre-hospital setting.
Yeah,
so it has to be the buccal midazolam should be available.
Yeah, so it's a pre-filled syringe, so you don't have to draw it. Yeah.
So I lost my connectivity in between. Sorry for that. There is actually power failure here. So that is why I'm logging in using my mobile. Regarding the hyperventilation, I think my answer was...
Dr. Ananda Madam has clarified it.
Okay, thank you. So almost 9:30 now. Dr. Kalpana, can you conclude the session now?
So it was a very useful session. Thank you, Minnie, for taking all the pains. In 2-3 days, it was done and everything was arranged in such a way that the whole epilepsy could be condensed and made in a capsule form for 1.5 hours to the maximum. Actually, this is a very, very simplified thing, and epilepsy is the bread and butter of any neurologist. And it is a very, very complicated thing, and we cannot simplify it much more than this. And so actually if pediatricians who are interested in it, if they can attend the PET program and also other programs on epilepsy. There are multiple single day workshops are there, and then they can do the initially actually what I will suggest is the diagnosis and the initial starting of treatment will be better done by a neurologist, and but the continuing care and the when there are some problems like the vomiting in between, or when they are taking other medication, whether what it will happen, and other comorbidities, all can be addressed by the pediatrician. So pediatrician should definitely have a knowledge, and also we should know what should be done in an acute setting when a child is coming with the seizure. And when status is also an important topic which we have not covered it here, because that is itself is a big topic.
Okay.
So
Actually,
we can
parents are more confident and more attached to pediatricians because they are seeing the children from the neonatal period onwards. So സ്ഥിരമായിട്ട് കാണുന്ന pediatrician പറയുമ്പോൾ അതിനൊരു കൂടുതലൊരു അവർക്കൊരു ഫോളോ ചെയ്യാനുള്ള ഒരു ഇതുണ്ട്. അപ്പോൾ അവര് ഡ്രഗ് കംപ്ലയൻസിനെ കുറിച്ചും അതിന്റെ അഡ്വേഴ്സ് ഇവന്റ്സിനെ കുറിച്ചൊക്കെ ചോദിക്കുമ്പോൾ അതിന് അതിൻ്റെതായിട്ടുള്ള ഇതുണ്ട്. അതുപോലെ ഈ വൈറ്റമിൻ ഡി കൊടുക്കുന്ന അങ്ങനത്തെ ചെറിയ ചെറിയ കാര്യങ്ങളൊക്കെ ബിസി ഒ പിയിൽ നമ്മുടെ 200 പേഷ്യൻ്റ് വരുന്ന ഒ പിയിൽ പലപ്പോഴും നമ്മളൊക്കെ മിസ് ചെയ്യാറുണ്ട്. അപ്പോൾ ഒരു പീഡിയാട്രീഷ്യൻ സ്ഥിരമായിട്ട് കാണുന്നവരുണ്ടെങ്കിൽ ഇത്തരം കാര്യങ്ങളൊക്കെ ചെയ്യുന്നുണ്ടോ എന്ന് ചോദിക്കാൻ പറ്റും പലപ്പോഴും. സോ ദാറ്റ് വിൽ ബി ഓഫ് ഗ്രേറ്റ് യൂസ് ടു ദ ചിൽഡ്രൻ ആൻഡ് ദെയർ ഫാമിലി. Thank you all for the patient listening.
Thank you.
Okay.
Thank you very
Thank
much.
you. Good night.
And thank you for all
Thank you.
the
Good
senior
night.
teachers and IAP, Dr. Riaz, Dr. Gopi, everyone has attended. And Dr. Gopi for an official vote of thanks.
Thank you. Thank you. Thank you.
Respected Kalpana
Thank you.
Madam, IAP Trivandrum President, Riaz, our State President, Kunju sir and other dignitaries. It was a very good webinar. You really demystified the epilepsy and made it very easy for us practicing pediatricians, because we usually are the first people who deal with these patients. I must thank IOP and Kalpana Madam, Mini Madam, Kunju sir, Dr. Rakesh and GC Madam. It was a very good topic and very good, excellent information we gathered from you. Thank you, Ananda Madam and Dr. Rajesh. A very good topic. Thank you. Thank you very much. And I also thank all the delegates. We had more than 100 people who attended this. Thank you very much. Good night.
Thank you. Good night.
Thank you. Thank you. Thank you, Mini, for doing an excellent job. Okay.
Thank you, Mini ma'am.
Thank you, sir, for being with us for this much time.
Okay.
Thank you, ma'am.
Actually, I am in the in the tool
Okay.
we are doing for my preparation of my textbook. Every day, a lot of that is why I don't get enough.
Textbook is a very big headache, sir.
Because editing, correcting, and all other things I am doing. Okay. Thank you.
Okay, thank you. Hello. ഇല്ല മിനി, അതിനിടയ്ക്ക് സാറ് സംസാരിച്ചോണ്ടിരുന്നത്, അതുകൊണ്ടാണ് ഞാൻ.
Okay.